Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Here, we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Hey, welcome to the final episode of season 2 of the Gynarchy. Today we're going to be talking about real facts about the human papilloma virus vaccine. And my guest today is Dr. Amanda Selk. Amanda is an OBGYN in Toronto, Canada. She's past president of the Canadian Colposcopy Society and has done a lot of work advocating for HPV testing as primary screening for cervical cancer in Canada. She's also a podcast host and discusses vulvovaginal disease education on the podcast called The Vulva Diaries. So welcome, Amanda. How are you?
I'm great. How are you?
It's nice to have you on. I've been following your posts. So I'd love to have you tell us first a little bit about yourself, how you got to do what you're doing.
So I'm an academic obstetrician gynecologist, meaning that I work in university hospitals in Canada. I think our system's a little bit different than the States, but I have clinical work, which is obstetrics, and colposcopy, which is dealing with abnormal PAPs or HPV testing. And then I do vulvar dermatology and dysplasia. And I really only do 3 things anymore. I do research, I do education, I have a fellowship program to train people in vulvar conditions. And I do a lot of work in international societies, including the International Society for the Vulvovaginal Disease and the International Federation for Colposcopy. So I do a lot.
Amazing. Thank you.
I'm a mom of 3 little people who are getting big and married to another physician. So life is busy.
Great. Well, you're the perfect person to talk to about this because, and I even though I'm based in the U.S. and my knowledge is about U.S. Healthcare with regards to HPV vaccination, I do have this podcast does have an international audience. So I think your background is going to be great to discussing that.
Right. And the vaccine's the same. So.
Right, exactly. So actually tell me a little bit about, I didn't realize until we connected that you had this very helpful podcast. So how did that come about?
So I, like you, spend time on social media, and there are Facebook groups for mother physicians. And I remember thinking about watching posts, and this was a while ago, maybe 7 years ago, where people were talking about how they have no time to go to conferences, no time to read books, no time to read journals, but they were starting to listen to podcasts. And my goal is I'm always trying to improve knowledge in vulvovaginal education because it's a very weak area of training in family medicine, OB-GYN, dermatology. Like it really is a huge area of need. So I wondered, just out there, could we teach this in audio when it's a very visual specialty? And I just decided to try, and it worked out. It actually has listeners in 127 countries. And if you look at stats, I did 39 episodes and then I felt I covered everything. But if you look at stats in podcasts, it's actually for global reach in the top 2.5%. So I think it really is amazing that it met its goal of trying to teach. You can walk your dog, go on a run. Residents use it for exam studying, but it's really for everybody. And it's interview with experts, kind of like what you're doing. So,
yes, I mean, my target audience, I like to think is, laypersons, who don't know much about our field. But to your point, I do think there are some students also listening, or even other physicians in other specialties.
It's interesting. So I designed mine as medical education for clinicians, but it's amazing how many patients listen to it. And actually, I find that patients even though we didn't target them, they get empowered with knowledge about their conditions, and actually sometimes they use it to get better care. Like, this is the standard of how this should be treated in these less commonly known conditions. So even though they're common conditions, people don't know about them.
Yeah.
So it's actually worked out quite well. And I'm always surprised how many patients come to me and say, I learned this from listening. So
Yeah, well, to your point, I also find, my vulvar vaginal disease education was, kind of not very strong, maybe because these conditions can be rare, right? And we have to cram in our specialty, oh, they're not rare.
They're not rare. That's the problem. So I think the problem is a lot of them are dermatologic, and gynae doesn't learn derm, and dermatology is uncomfortable in genital areas. That is truly it. Because if you have diseases that are 3 to 4% of people, that's debatably not rare.
Good point. Yeah, I see lichen sclerosis all the time, but now I've just become a big believer in doing biopsies, because I've diagnosed the melanoma, and then just this past week, vulvar precancer, so.
I'd say you're doing a great job.
Oh, thank you. Well, now I just have a lower threshold because I'm just realizing, like, wait a minute, what I thought was like, oh, let's just try topical steroid was, can turn out to be something more serious,
A lot of it is looking too and knowing. So you need to actually look at the skin. And it's funny, people look at the cervix, but they don't always look at the skin. And then you miss things. And unless people have like complaints, very advanced lichen sclerosis, when your anatomy, you have no labia minora, it's all white. Like, people don't tend to miss that. It's
right
if they go and look. But again, as cervix screening, we're spreading it out in many countries to 3 to 5 years, depending what test you're doing.
Right.
And then there's recommended that you don't do exams for like gynecologic internal exams, pelvic exams without any symptoms is a very debatable thing to do. But then what happens is no one ever looks. So already they weren't looking, and now they're looking less. So I'm worried that these things are going to become more problematic.
Yes. I mean, with the shortage of physicians, people going in for in-person exams less, right? Or even if they have a lesion, not being able to be seen in a timely manner. So I agree.
And most cancers come up advanced because of two reasons. People are uncomfortable going to see somebody, and then clinicians are uncomfortable. Like, they don't see enough cancer to know. So.
Right. Yeah. And so I guess back to what I was saying earlier, I guess then maybe the problem was that, I feel like we're cramming a lot in a 4-year residency, at least in the US, it's 4 years OB/GYN residency. And so there wasn't enough clinic time to really, get comfortable with diagnosing. Well, diagnosing.
So training is all about obstetrics and surgery as opposed to clinic, when most of your life when you're done is actually clinic. So
right. Good point. Okay, well, let's get into it. Obviously, I wanted to, obviously all of these diseases, vulvar, vaginal, cervical cancers are linked to HPV, human papilloma virus infection. And so, I wanted to talk about the vaccine because, as you know, we're definitely in the US, but maybe internationally, we're living in these times of vaccine hesitancy and a lot of suspicion about vaccines. So I really just wanted to, and I do this, I have to talk about this a lot in the clinic as well with parents, parents who are hesitant. So I thought it would be good to have a podcast episode to basically kind of inform patients and parents about the vaccine, and also hopefully demystify, and answer some of their questions and address some of their hesitations. So I guess let's start with the basics. Like, maybe patients won't know what human papilloma virus is, especially young people.
So human papilloma virus is a very common virus. About 80% of people in Canada and the US will get an HPV virus over their lifetime. The vast majority of them will clear it. I think of it as getting a cold. We all get colds. Most of the time, our immune system can deal with it fine and clear it. But sometimes you don't clear it. And persistence of having a high-risk HPV strain is what leads to cervix cancer, as well as a whole bunch of other cancers like head and neck cancers, anal cancers, vulvar cancers. But in women, cervix is number one. In men, head and neck cancers are number one.
Okay. And also penile cancer, but that's rare,
Yeah.
right?
Yeah, that's rare. Yeah. And so HPV can cause both genital warts, which are called low risk non-cancer causing strains of HPV, as well as the cancer causing strains. So I said 80% of people will get an HPV strain, about 30% will get a cancer causing strain. So it's super, super common. And what's amazing is we have a vaccine that we can give to help prevent getting this virus.
How common is oropharyngeal cancer in men and women?
So I'm getting old. And when I went to medical school, the top cause of head and neck cancers in men was smoking and alcohol. And now it's not. Now it's HPV. And it's a rising cancer in men. And actually, because it's like increasing in, I don't have an exact number, but we know it's increasing and becoming much more common, and that it's due to HPV. You're seeing a lot more of it in the news. Like I actually found trying to get press for cervix cancer is difficult, even though cervix cancer is actually the fourth most common cancer in women in the world. It's less common in high income countries like Canada, the US, UK, Australia. And that's because we have screening programs with PAPs or HPV screening that helps detect precancers we can treat. So that those programs work well, but what works even better is getting rid of the cause in the first place. Like we actually understand the cause of the cancer here, and we can prevent getting it in the first place.
Mm-hmm. It's interesting that you said that it's easier to find more info about head and neck cancer in men versus cervical cancer in women, but perhaps that's the angle to make it important in this patriarchal society is to focus on how it affects men.
Well, this is right. So Cervix Cancer Awareness Week happens in different countries, actually happens at different times of year. But a few years ago, the big news story, at least in my country, was about head and neck cancers during Cervix Cancer Awareness Week. That's what got all the news. And I was like, right. Because like when I talked about the vulva problems earlier, it's the same thing. I said, if men had a disease where their skin was scarring all together and making it really, looking terrible, they can't have sex, etc., it would be everywhere and there'd be lots of funding. So it's the same,
right?
It's the same here. It's very prevalent. So back to history, right? So usually they talked about HPV vaccines just in women in Canada and the US. Australia did men and women to get boys and girls together at school from the very beginning, and Canada and the US did girls first and only caught up with boys later because they were only talking about cervix screening and that whether it was helpful to do the boys. Like to me, it makes sense because you all share everything together. But now that we know that there's male cancers, the boys have become more important.
Right. So hopefully that will, whatever it takes, right? I mean, certainly it's, and also for the herd immunity, like it's a human disease. It's shared among men and women and right, exactly. And all of these cancers can occur in both. So, not vulvar, vaginal, and cervical in men, but still head and neck, the anal, penile.
Yeah. And it's interesting. So places where they started vaccinating first. So again, go back to Australia. They did boys and girls together, and they were the first country to do it. And they just, the whole country did it. And they got really high vaccination rates. And they were the first place to see benefits from it, right? Like, so their sexually transmitted infection clinics don't see warts anymore. And like their young people aren't getting warts. And I can tell you, no one's happy about getting genital warts. Like they're also, it's a huge healthcare burden. There's lots of stigma. Like it's not a nice thing. But again, the vaccines help prevent warts and prevent cancer, which again, we could talk about numbers. So that was like the first thing to go. And now we're starting to see all the, changes in precancers and other things. But because cancer takes many, many years to develop, usually you have to have persistence of the HPV virus for 20 to 30 years to see a cancer. It takes a while to get data to show that the cancers go down because these vaccines were only approved in 2006. So it's almost 20 years, right?
Okay.
But we're still seeing benefit. So this way, when people say, well, we don't see cancer benefit, like we do, because we see decreases in precancers. And as somebody who actually a lot of my work would go away I will make less money and have less to do if we had all vaccinated people. So amazing, more time. So
yeah, I was sorry, go ahead.
In our clinics, no, but most people in our clinics with the precancers that we're treating, they're not vaccinated people, the vast majority. So
right, I see that too. Okay, well let's talk about the vaccine. So, and I'm glad you brought up that it prevents warts too, right? Because so let's talk about now. The other thing people misunderstand is HPV, the HPV virus. It's actually dozens of viruses, right? And some cause genital warts, some cause cancers. And so, and the vaccine is, well, tell us about the vaccine. And
so the current vaccine the main vaccine that's being used now in Canada and the US is, are we allowed to call names? It's called Gardasil 9, and it covers.
That's what I call it.
Yeah. So it's a non-avalent vaccine, meaning nano is 9, Greek or Latin. So there's 9 subtypes of HPV that it covers, and so HPV 6 and 11 cause 90% of warts. So it's effective in preventing 90% of warts, and the other 7, like HPV 16 and 18, are the most cause 70% of cancers, cervix cancers, and by adding those other 5 strains, you cover 90% of cervix cancers. So they're not perfect, but 90% is really good. So we still need people to be screened who are vaccinated. But again, you've reduced your risk. And the vaccine works the best if you get it. Well, first of all, your immune system reacts better to vaccines when you're younger, which is why we give vaccines to kids in general, because they just have great immune systems that react better and make more antibodies, right? But the other thing is that this vaccine works the best if you've never been exposed to any virus. It doesn't mean it doesn't work if you have been exposed, but it works better if you get it before you're exposed to a virus. And how do you get exposed to the HPV virus? Any sexual activity whatsoever, whether that's touching, genital touching, hand to genital, oral genital, genital, it doesn't matter. And it just, you want it before any of that ever occurs.
Right. It works best before exposure. I know because some parents will definitely hesitate to giving, say, their 9-year-olds when we start introducing that you can get this vaccine, the vaccine, because they don't expect their 9-year-old or 10-year-old or 11-year-old to become sexually active. But, right. I vaccinated my kids as soon as they could, probably at 9 or 10. And I didn't even want them kissing before they got the vaccine. But I don't know. I know it's not really indicated, like it's not a prophylactic given before kissing, but I just thought of that all in.
There's lots of good evidence. Like vaccines do not lead to sexual activity. They do not increase it. Your kids are not thinking about it. And most people who think their kids are not doing anything are living in under a box of some kind. Like they're in the dark. Like, people always think their kids are not doing anything, and they're wrong. And so like maybe your kid is perfect, but in general, kids are doing more than their parents know. And that it does not lead to sexual activity. Hepatitis B is the cause of a lot of liver cancer. And it is also a cancer causing, like the vaccine is to prevent liver cancer. And although you can get Hep B from from blood and other things, again, vast majority is sexually transmitted condition. And no one talks about it and no one worries about it.
Right.
And you guys in the States, you give it when the kids are like brand new, like newborns. We actually give it with our HPV vaccine in Canada. We give them all in grade 7, unless you feel you need it earlier or there's like parental transmission to their kids. But generally, it's funny. Like we just do those together.
The hepatitis B and the HPV.
We do Hep B and HPV together, and meningitis all in school-age children. And in Canada, they're all publicly funded. So everybody gets them in every single area of our country for free.
So is it part of the national, like the schedule that everyone should get that? Because in the US, it's option, it's not mandated.
It's not mandated, but it's recommended and funded. It's free. In Canada, it's free if you get it at school. So because it's very clear that it helps. And there's many countries have publicly funded vaccine programs for HPV, but those are healthcare issues. But anyways, it really is, when you have programs, it's easier to get uptake. But again, there's variation across different parts of the country, the same way you guys have about uptake and not.
I don't think our uptake is as great as some other countries that, say put it on their, the schedule, but there is good insurance coverage. I would say that,
But anything that involves having to go to get something, like if you have to go to a doctor to get it or a vaccine clinic, whatever, versus, actually going to schools, the parents still have to sign off on it and opt in and everything, but it does increase how many people can get it. Yeah.
Right. That makes sense. I think sometimes people have fears about how the vaccine is made. Yeah. So I don't know if you can address some of that.
Types of vaccines. So some of the vaccines are live, where you're actually using part of the virus. This is not a live virus. It's actually uses a viral-like particles. So you can't get HPV from the virus. It's been given 500 million times across the world now, 500 million. That's a big number. And even with rare side effects, when you get that many, you really see stuff. We know this is a super, super safe vaccine. The most common side effects are site reactions, which means your arm is red, sore, swollen, like any needle, can be sore. Of course, there's fainting. And I joke, because you give it to a bunch of teenage girls, you're going to get fainting. But they're not serious. Headache, malaise, basically the common things in any vaccine, but nothing serious, are the same as, again, really, really rare. So we don't worry about it. It's safe. It's fine. I've had it. I think,
I actually.
High risk HPV every day. And then 2 out of 3 of my kids have had it. The only one who hasn't had it is because they're too young. But my kids were the ages during COVID shutdown where they needed it. And I worked really hard to get it for them, because I just don't want them to get these cancers that we can potentially prevent with a vaccine.
Yes. Yeah, to your point. Yeah, both of my kids are vaccinated. I'm vaccinated, and I actually got vaccinated over 45. So I paid cash, cold hard cash, because it wasn't covered by insurance. But I opted to take it, even though it hasn't actually been approved for people over 45, but research is suggesting that will be helpful for older people as well.
It's hard to know. And I was also way older than over 40 when I got it, but I treat HPV disease all the time. I'm burning it. It's in the air. It's all over, and we don't know. And again, you don't want to be the case report of a head and neck cancer from the clinic. I'm treating it all the time.
Right.
So, I just figured that that's also another, you never know, right? And it's not funded either in non-school age children. So $200 a dose. And again, dosing schedules have changed, but it used to be 3 doses. So that's $600. It's a lot of money. But I still thought it was that important to do it.
Absolutely. So yes, I think that's good to point out. Healthcare workers who are exposed to or treating HPV positive patients, it's an indication.
Maybe we don't know, right? And I don't. Okay. But to me, what's the harm? The harm is money and your arm. But that's it. So if you can, afford it, I think again, for the general public, you want your kids to do it. If they didn't do it, it's not too late to do it. It just may not be as good. But it's really hard to say it's zero effective, right? So because chances are, who has all 9 strains of HPV? Right? It's hard to get online.
Right.
And so even if you have been, sexually active, or even if you've had an abnormal, you might clear it, and we don't see long-term immunity from clearing it. Again, some things, chicken pox, you get it, you don't get it again. That's not the case here. You can keep getting HPV over and over and over again. So the vaccine seems to provide better immunity than your own, because that's a myth people have, that, maybe if I have it and clear it, I'm more immune, and you're not.
Right. You may have just cleared one strain, right? So,
well, and also you can still get that strain back again. Just because you've cleared it doesn't mean you're now immune to that strain. It doesn't work like that.
Yeah, I do see patients, who come in So, that's something really good to, it's important to spread the word. Like, even if you have an abnormal pap, even if you have tested positive for HPV, even if you have warts, if you have not been vaccinated before, it may still be helpful against the other strains, right?
Yeah, yeah, they're not therapeutic vaccines, meaning at the moment, the vaccines we have are not treating what you have, but they may help you from acquiring more things. And if you clear it, it may help you from getting the same things back. Like that's the message. They are working on developing other vaccines that you can use to treat stuff, but we don't have them yet.
So sometimes this is actually a question I want to ask you. So I have patients who will tell me they'll come in with a new positive HPV PAP for treatment or to address it, and they'll tell me that their previous PAPs were all normal, HPV negative, but in the remote past they had a positive HPV PAP, and it's awkward if they're in a long-term relationship. Because, well, I say frankly, it could be a new exposure. So I guess how do you address this?
So there's three possibilities for the answer to your test. So one is there's rare cases of false positives in testing, like not every test is perfect. That would be a rare scenario, but not impossible. New acquisition, so potentially they've been exposed, as you say. However, there is also actually quite a lot of studies that suggest that you can reactivate a virus that's gone dormant in you. So that is very important. So, and we don't have a test for it. So what it seems to mean is that when we say you clear it, it means that the tests we have can't detect it, but it doesn't actually mean it's for sure 100% gone from your body. And I can see this. We've seen patients who are 100% not sexually active for like 30, 40 years. And then all of a sudden they have these abnormals show up. You see that with herpes too, to be honest. Like it can be quiet for many, many years, but your blood always stays positive, but like you never had an outbreak. And then all of a sudden you're sick in the hospital, you're 80, your partner died years ago. And that's your first herpes outbreak that you know of. So it's not a unique to HPV thing. And I think that's important for people to, again, understand, because as you say, automatic feeling is, oh no, somebody is having an extracurricular relationship, et cetera. And it's not necessarily true. So, and we have no way to show that. So reactivation of a dormant or quiet virus is very possible.
Okay, thank you for sharing that. And that is what I've been telling patients. Well, herpes, and I have been using herpes as an example, that it can reside in your body and show up all of a sudden.
Something like 20 to 25% of adults have a herpes virus, and 90 to 95% don't know they have it. So it's a good analogy. Like people have no idea that it's there.
Right. Before we go further, I just want to talk about the schedule, and at least here in the US, and I imagine this is universal around the world, but here from 9 to 14, it's 2 doses given, 6 months apart, and above that age, it's 3 doses. And the typical schedule is like 0 to,
6 months. Yeah, so that's changing actually.
2 months and 6 months.
I think you'll see a difference in that soon, because there are actually many countries have switched from 3 to 2. And actually, there's evidence that even 1 dose, unless you're immunocompromised, that actually 1 dose has such effective coverage that the World Health Organization looks like they're going to actually start recommending 1 dose. But for now, you follow the recommendations in your country, but it looks like you get such good immunity when you do the young people that's why they went from 3 to 2. Because again, first it was 3, then it was 2. I think it's coming that it's going to be 1. Okay. But most countries, Canada included, UK, Europe, have gone to 2 doses actually in adults now, unless they're immunocompromised. Okay. So good to know. I think that's actually new and hot, and pay attention, because I guess, I don't know, based on things going on in the States right now, when vaccine data will change and recommendations, because I think it's not a top priority at the moment. However, it is nice to have less needles if you don't need them.
Yes, and I actually think it is going to become very important to like that point, like one vaccine is enough, being enough is important here because I mean, I've read that they're moving to that recommendation in other parts of the world where there aren't too many resources. And I mean, the US is becoming like that,
Well,
frankly. So,
I don't, I think for sure, even high income countries will not be three, except in immunocompromised potentially. Everybody will be two, and it may move to one, but low income countries for sure one. And again, stay tuned because I've been at a bunch of meetings where there's a lot of people involved in international things, and I think the one is coming. So.
okay, good to know. Okay, I want to return to talking about some of the safety issues just to kind of dispel some myths. I think okay, I don't know how often concerns about like long-term risks with the HPV vaccine come up, but I know with other vaccines, people will talk about things like autism or, birth defects or,
Yeah,
fertility.
no, we don't have any data. Like none of those things seem to happen. Like I said, 500 million doses. It wasn't indicated because they didn't do the original studies. You never study vaccines in pregnant women. Like that's not a thing. You'll never get approval, right? But then
Right.
now we have tons of people who've accidentally had it pregnant because they didn't know they were pregnant early on. And again, we haven't seen any problems. I think usually if we as an obstetrician, we always like to, reduce what we're giving to people. So if you know someone's pregnant, we don't give it to them, but we also don't worry about them if they accidentally got one while they were pregnant
Mm-hmm.
and didn't know because we have seen zero concern.
Right.
So
So the most common risks are just like injection site things, and maybe like how often is like an allergic reaction going to happen to this vaccine?
gonna be
Super
very
rare.
rare. What number do you give? I'm just rare. We say rare. Like all vaccines, you just sit there and watch people for 15 minutes, right? And it's a
Yes, it's probably less
mixture.
than a fraction of a percent. Yeah.
I can't remember anybody, right? Like
Yes.
I actually can't remember one
No,
ever.
I can't
So
either. So I wanted to talk about like what if someone I guess we already kind of addressed this because you said one vaccine may be effective and maybe switching to
yeah,
that. Because what I wanted to ask about was like if someoe's interrupted their schedule,
yeah.
like
So
do you
just
have
this
to can you resume it or do you just forget about it or do you restart it?
So I think that's changed. Like we've watched that change, right? Where when we didn't have a lot of data, the companies would say you have to restart everything. But again, their interest is vaccine, and ours isn't. Like
Right,
their interest
right,
is giving it,
right.
and ours actually isn't. And as we've got more data over time, then it was like, no, just give it when you can give it. And like I said, now it's looking like doesn't probably matter. People do ask us sometimes about bumping up. Say they had. So there used to be Gardasil for cervix. So cervix only covered the two cancer causing ones. Uh, it's become less common. It's still used in the world, but I don't think it's used much in Canada and the US, although it's approved. Gardasil 4 covered the two wart strains and only 16 and 18. So some people had that one and then they ask, should they get the new one? And that is a very individualized conversation because, again, you had 70% cancer coverage with one, now you have 90%. But actually, probably if you were going to give the new one, you only need to give one dose. You don't need to give them the whole series, which is what was happening. Again, evidence wise, probably don't
Right.
need to do it all. Um,
And then like if
this is all
someone
new, cutting
and
edge
is
things.
right, right. And I mean, we've had the vaccine now about 20 years, almost 20 years, but do you think I mean, what do you think about the need beyond? I guess as we get more data, we'll learn if we need to
A booster.
revaccinate people
Yeah.
after a certain age,
That
right?
you we don't know, like we know it's lasting from that group that got it initially, but will you need a booster later in life to be determined, right? But for now it's good. Like now I think the concentration is still trying to get the younger get a higher uptake in younger people would be the place to concentrate resources on. So if you look at official approval ages, I think that was important. Like, so it's approved for 9 to 26 age 9 to 26 originally in women, and then the men were added. So now they're both there. But then there's this potential only in women, this 26 to 45 gray zone of talk to your doctor about benefits for you. But again, it's not that it stops
I thought
working.
that also applied to men.
So men, no, well, again, country dependent. So because the cancers, it's what they're looking at too. Like what's the outcome they're looking at? So in men, they're looking at anal cancers and men who have sex with men and other things, but they're not looking at, because we don't have a way to screen for a precancer for head and neck.
The head and neck.
We just have the cancers. Like we don't have a test to say you have HPV in your head and neck. Like we can test the cancers and show that they're HPV related, et cetera, but we don't have a screening test. We don't know how to test guys. Like we don't have any of that. So I think that's the problem. Like they don't have that to use as a metric on what age it's useful for to prevent head and neck cancer. Right.
So can I just tell you, yeah, that's interesting because, I need to probably talk to my dentist a little more about this, or dentists in general, because my dentist offers an intermittent oral cancer screen with some kind of rinse. Like, am I?
Yeah.
I don't know. I guess
I don't know what they're doing.
Development.
Maybe they're putting, I wonder if they're
with a light
in your mouth. Maybe, right. I don't know what they're looking for, but they do seem to feel, our dentists, like they feel around and they look for lesions, like they're looking for, but we don't have any, again, they don't understand that whole pathway. Like with cervix, we know everything. We know a lot about cervix. Like we know with squamous cancers, like we know the virus, we know the changes, we know how to treat them. Like with precancer, you can cut it out and get rid of it. Like it's a kind of amazing. Like we really, compared to many cancers, it's quite a cool what we understand. So
right, and I feel like that's missing with the oral, cancers.
But it's coming. Okay, and it's coming with anal cancer. So that used to be there. There was a lot of stuff about how there's no point in screening for anal cancers because we don't know the pathway, but like we don't have a thing. But actually, U.S. stuff. So Joel Pulafsky is Canadian who moved to the States in California. He is an infectious disease doctor who developed high resolution anoscopy. So looking into people's bottoms for precancer. And he's actually over time been able to change the world and show actually you can find the precancers, and yes, you can treat them and you can prevent. So we do have that now. And it's a lot of work from one person that's spread, but he was very dedicated to this. So
okay, that's
it's funny. I don't feel old, but sometimes I feel old because I was like, that's in my 20-year career. Like it's amazing how from 20 years from residency till now, like watching how these things have evolved. Right. So
it would be so great to diagnose these things much earlier than when you can feel it. That's quite large and advanced,
But again, we still don't have enough people who have learned those skills and can offer them everywhere. So again, they're focusing on people who are, again, we have people who are more at risk, like if they are also immunocompromised, but there's still plenty of people who are healthy and at risk, right? But from knowledge to practice takes on average 10 to 15 years from when you know stuff to when you really get it out there to the public. It's frustratingly slow.
So like, what are your thoughts about recommending it beyond like the above 45 group, like the value of paying out of pocket for a dose?
I think you have to understand that how much of a bump do you get and how long does it last? Like I said, your immune system doesn't seem to react as well. I don't think it's a total waste. I just don't think it's as good, right? And so as long as you're willing to accept that you might not be getting amazing benefit, maybe just a small benefit, small chance that nothing. But like, I think, again, most people who are doing it are trying to help themselves and we don't have much else. So the big risk is my knee and your arm might be sore. But other than that, everything else is way more in common, right?
Right.
Just however you usually react to vaccines. Like some people don't feel great for a day, but that's anything.
Can you speak to the impact the vaccine has had, maybe globally or just since it's...
I told the excitement of warts is like, I think that's really exciting. That was like the first thing to see. But we're also seeing like less precancers, high grade or high grade are like the high level before cancer. That's what we call them. So we're seeing less of those in the younger people who are vaccinated. So we are seeing this benefit. It's coming. And again, we see it first in the places that vaccinated first, right? And in places where vaccine uptake hasn't been good, we have way worse cancer rates, right? So in the world, I told you, cervix cancer, fourth most common cancer women. In Canada and US, it's much more uncommon because, again, we have screening, but no one who's happy to have a colposcopy. So colposcopy is where you come to a gynecologist generally, and you sit with your legs up like in a pap, and we put vinegar on your cervix to look for precancer cells. We often have to biopsy. We have a fancy microscope called the colposcope. So we're looking between your legs at your cervix. And then if you have a high level precancer, we have to cut out the cells. And again, we can do this in a calm way, and it's minimally discomfort, like getting dental procedure done. But still, it's very anxiety provoking for people. Like there's lots of people who've had trauma and don't want to have, exams are hard for them. So if we can, again, avoid all of that, because some people who are anti-vaccine will say, well, you guys can treat stuff. We can, but I've yet to meet someone who wants to be in that clinic. Right? It could be my entire day, every Monday, all day. That's what I do. And most people say, you're really nice, but I wish I didn't have to see you. So
I think that's such a good point, important point to bring up that yes, you can, a majority of HPV can be cleared, but to avoid all of this care for treatment of, say, physical warts or abnormal paps and frequent visits to the doctor and, right, like you said, trauma of all those procedures is a reason in itself to get the vaccine.
I will say sometimes when we're taking care of younger people where their parents made the decision for them and didn't let them, their kids are actually kind of angry with their parents. So just to know, like your 22-year-old who you didn't let, and I don't know if they go home and have these conversations because they're now adults and they're in the clinic without their parents and they are not always happy about the decision that was made by their parents.
I'm really glad you brought that up because I have had these patients that come in at 18, when they're finally, able to make their own, or whenever they're able to, they're free and can make their own medical decisions. And they're suddenly trying to get all the vaccines that their parents did not let them get. And I've also seen another scenario where a parent declined a vaccine and then the child did become sexually active and a young person and had an abnormal something, an STD or the vaccine, HPV, sorry. And then they're trying to get the vaccine then or, address things kind of late, So,
And again, as you said, treatments, it's not just treatments, although are again, lower risk, there's still risks to them, whether pain, bleeding, infection, preterm birth, preterm birth scares a lot of people. So, but I'm also, if you get cancer, you're probably not going to be having a baby. So it's always these balancing of risks, but vaccination, although not perfect, can prevent so much of this.
Right. So. The other thing is, I know that a lot of cases are cleared, but I've also had, I'm sure you've had patients like this too, that for some reason or another can never clear the HPV. It's just seems to always be positive, like a chronic HPV infection. How often is that happening?
So I don't think we know a number yet because, again, HPV screening and testing hasn't come to general practice until relatively recently. And also subtype specific, where you can actually see which strain. So are they, keeping the same strain? Because it's actually persistence of the same strain. If you're actually switching strains around, not so high risk. You're actually higher risk if it's day 16.
No, I've seen one strain be positive, and
that's the person you're going to worry about. So, that's a person that you need to keep an eye on. So we know that certain things put you at higher risk. Now, just because you don't have these things does not mean that you shouldn't be followed. Okay. So remember this, but if you smoke cigarettes, we don't know anything about marijuana because I always say with something still illegal in places. Some places it's legal, some places it's not. It's very hard to study. But smoking cigarettes is a risk factor, probably because your immune system doesn't clear the virus as well when you're a smoker, the same way it doesn't clear a lot of things as well when you're a smoker. Having immunocompromised conditions like HIV, having a bone marrow transplant, having lupus, actually, lupus specifically is quite a high risk of disease. You don't even have to be on treatment. Okay. Then any immunosuppressive drugs, like the biologics, like all of those fancy drugs now that they're using for rheumatoid diseases, for Crohn's disease, for eczema, like all those fancy things, I feel like they're good for one disease and not always good for another disease. So they seem to affect your ability to clear. You probably have to be on them for a few years, but generally the recommendation is more often screening for you. Transplant patients, if you've ever had a kidney transplant, you have really hard to treat HPV. I live in a huge Toronto is one of the big transplant places in the world, and in North America, like we're huge. And so my poor transplant patients tend to have HPV all over the lower genital tract. And I just keep treating them, and they're never going to clear it because their immunosuppression for their transplants prevent them from clearing their HPV. So again, if these people were vaccinated before they had any of their things, they would be better off than trying to do anything with them now, because also they don't respond as well to the vaccine because their immune system is down from their conditions or treatments. So more pull for why you need to get people early on their health.
That's a great argument. I mean, you also don't know what you're going to develop in life, like correct. I didn't realize that about lupus. I didn't realize that about those immunosuppressive drugs, because a lot of people are on them for various things now. I actually used one for a brief time for eczema, and thankfully I came off and I don't have it anymore, I taught you something new today. Yeah. Thank you. Do you recommend more? So I follow the usual screening schedule, but do you feel like for these patients, I should be screening them more often?
Yeah, no, most places. So yes, they need more often screening. And the question is what that is. So in Canada, we just talked about that. So if you're HPV negative, we do, 5-year screening, where I think you guys are still doing three, right?
For just, if it's HPV only screening, but we do both, dual tests.
Yeah, co-testing. So co-testing, if you're negative helps reduce the risk a little bit. This gets very complicated. But anyways, places that are 3 years could go to 5 years if you're negative, but they never go to 5 years if you're immunocompromised. So they are always 3. Places, they used to do one every year, but if you're positive, again, like we do 2-year screening, instead of screening, depending on the country.
Right. I am screening more aggressively for HIV positive patients, but these other patients are going to be,
They should go in the same group. They're all the same. So that group should be whatever you do for your HIV patients, you should be doing for that list that I just told you. So that's most of the, and the problem with the biologics is that there's so many of them. So it's too hard to figure out if one is higher risk than another. Like we don't have that data yet, and it's going to take a long time to get it, right? But why put people at risk while you're waiting for it? Like it makes sense. And I actually find their GI doctors and other people giving them, they actually do tell them you need more screening, but there is a lack of communication between specialties about some of this.
Yes. Look, I don't think the dermatologists, at least that I'm familiar with, are saying that, but I will bring that up now. So thank you.
And it's in a lot of guidelines in the world. So it's not out there. Like it's not random, like it's there. I think the US might have said that they don't have enough data for the biologics yet, but again, other countries have said we think there's enough to say, like, why wait for a problem, right?
Yeah, like I would agree. Yeah, thank you.
And we have the most data for HIV and transplants because again, like they've been watching them for longer, but I see lupus all the time, and lupus papers keep coming up, and I think it's an unrecognized risk.
Right. I think that needs to go on the official
DMARDs, that disease modifying anti-rheumatologic, those things, DMARDs, that family, that's also like methotrexate and Plaquenil and all of those drugs too. So yes, derm and rheumatology drugs.
Okay, thank you. So this has been a wonderful chat. I want to do a future episode about how to manage, when you get an abnormal pap. So I might have to have you back. I hope you'd be open to that. That would be great.
I'm impressed that you filled an hour with this, but that's okay. You said you would, and we did it, but we went all over the place and talked about other things. But that's how you do it because, I feel like I'm used to trying to give as much information about this as possible in more like 3 to 5 minutes. So like, you're
I
doing it for a
know.
newscast or whatever. Like I do those. So I think it's this like, wow, we could just spend more time on it and talk about it in more depth. But
Well, there's a lot to talk about. And yeah, in the office, I have to do it all in 10 to 15 minutes, but I just target it to the patient and her particular medical
like,
history and concerns. But it's nice to talk about all of these various scenarios. So I appreciate your
like
time.
I would say as a take home to people, like, getting an HPV vaccine, it's so amazing that we have a vaccine that can prevent cancer. And for sure in women, probably in men, it makes sense. It's safe. It's been used. We have lots of data now. This is not new anymore. It's almost 20 years old, and 500 million doses is a crazy number. So, and the US alone is like probably closer to 200 million. Like the US has like lots of US data. So,
Yes, a low
it's
risk.
safe, effective, accessible, here we are.
Right. Cancer preventing vaccine. Like it's a
and you're
no-brainer.
Two doctors who've done it for themselves and their children. And like I said, if you were all vaccinated, I would have less work to do and I would be happy about it. So this is not for me. It's
Same.
for you.
Same. I don't want to diagnose cancers anymore. These preventable cancers.
This idea that we get some benefit from it, it's our only benefit is helping prevent cancer because we don't want to see it. And that's it. That really
wonderful. That's a great closing message. Amanda, please share with my audience where they can find you if they want to hear more of your thoughts, read your thoughts, or.
So social media wise, my public accounts are on LinkedIn, Dr. Amanda Selk, SCLK. I'm on Blue Sky. I'm still on Twitter, and those are the ones that I use. And you Google me, I've done lots of interviews about this sort of topic before. So there's things out there. There's other versions. And my podcast, The Vulva Diaries, if you want to learn about vulvovaginal disease, you can, it's on I still pay to keep it up there because the knowledge is important and it hasn't changed. So it's on all the different podcasting apps, on your Apple, on your Spotify, on your whatever, it's there. So
awesome. The Vulva Diaries. Yes. It's great. Yeah. Thank you. Okay. I leave with a closing thought. So I'm going to do that. The patriarchy has a desire to control women's sexual behavior. And as such, the need for HPV vaccination is often minimized. Instead, women are asked to be pure and chaste and avoid sex. But in the Gynarchy, we know that women are allowed to have sex when and if they please, and that sexual assault also exists. And therefore, HPV vaccination is a smart, necessary measure to avoid serious diseases. So down with the patriarchy and up with the Gynarchy.
I said, if your partner ever had another partner, they're still giving you HPV, right?
That's right. You never know. So, okay. And so this is my last episode for this season. So I wish you all a nice summer break. And I hope you'll use this time to catch up on past episodes. And please follow us on our socials to keep up to date with what's coming. So take care. Bye.
Bye.
Did you enjoy this episode of the Gynarchy Podcast? Know someone else who might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Blue Sky, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.